Hi, everybody. My name is Dr. Khan Kao. I'm today joined by Dr. Jaesu Han, who's going to talk to us about a combined program of family medicine or medicine psychiatry. Welcome, Dr. Han. Uh, Thank you for your volunteering your time and knowledge to help medical students and future doctors.
Oh, you're welcome.
All right. I'll start with the first question. Can you briefly tell us how long you've been practicing, and then briefly discuss your jobs and what kind of day-to-day things you see and do?
Yeah, sure. So I've been in practice since 2002, so 18 years now. I spent the first 16 of those years over at UC Davis in Sacramento, California.
Hmm.
And for the past little over 2 years now, I've been at UC Irvine
Okay.
in Southern California. Now my position is an academic position,
Hmm.
and so I do several different things as part of my job. I work in the hospital as a consultation liaison psychiatrist, so I assist other specialists in the hospital managing their patients with psychiatric illness. I also supervise psychiatry residents doing outpatient psychiatry. And then I have a primary care clinic at a local FQHC, so I do my primary care there. And then I do consultation for the primary care doctors in psychiatry at that same clinic.
Oh, wow.
And then I have several different consultative work, working with different health systems in the area of integrating primary care with psychiatry. So that's kind of what I do now. And then when I was at Davis, I did much of the same thing, except I was also the program director for the combined family medicine program there for about 8 or 9 years.
Okay. That's some pretty good experiences throughout the years there. For the most part, medical students like myself, when I was a medical student, don't know what specialty to go into. How did you figure out what you wanted to do with you mean going into combined program?
Yeah, so when I was an undergraduate at UC San Diego, I really didn't know what I was going to do until I realized I wanted to do something where I can work with people, improve their health.
Mhm.
And so when I went to medical school, family medicine seemed to be really the field that was a good match for me. And that's what I was going to do until my very last rotation in my third year when I did psychiatry and found myself really enjoying helping people with their mental health. And I would have probably done family medicine, except a combined program opened up the year before
Uh,
at UC Davis. And so I found myself applying to a combined residency program at that point, and that's kind of how I ended up doing combined training.
Gotcha. So how, mean, a lot of people know family medicine, internal medicine, and psychiatry. How rare is a combined program?
Yeah, so it began in the early 90s,
Hmm.
and there's only 5 programs in the country where you can do combined training.
Oh, wow.
So it certainly is not going to be a career choice that you're going to find in every location around the country.
Hmm.
So San Diego, UC San Diego, UC Davis,
Hmm.
Pittsburgh, Cincinnati, and then Medical College of Massachusetts, I believe, in Boston.
Hmm.
Uh, those are the programs that are available.
Oh, wow. So that not too many. So,
Not too many. And each program typically takes 2 residents per year,
hmm.
and that can seem daunting actually to people who apply, but really it's a particular niche, right? So you really have to want to do both specialties. So even though there may be a lot of applicants, really, I would say many of those folks are really kind of window shopping.
Yeah.
So that the students who truly are interested in doing a combined program is actually a much smaller number than one might think.
Gotcha. Oh, gotcha. So there might be only like 10 residents per year total.
There's about 10 residents per year, but again, once you kind of get through all the folks who are just sort of thinking about doing combined
Mhm.
training and you get to the folks who really are very serious,
Yeah.
it actually ends up not being quite as daunting as it may first appear.
Do most graduate residents end up doing both medicine and psychiatry?
Yeah, I mean, I wouldn't say it's like everybody's exactly a 50-50 split. And in many jobs there's quite a bit of I won't say variation, but it depends day to day and kind of what you do.
Yeah.
It really boils down to what you're interested in. If you really are interested in doing both things, you'll find ways to incorporate those two specialties into your work week. The other main thing I would just point out is that there's a lot of mental health in primary care, and there's a lot of primary care issues that come up in mental health.
Yes.
So there is quite a bit of overlap.
Hmm. Yes. So, what other specialties were you also considering besides the combined program?
Well, I'll tell you, when I went to medical school, I was pretty sure I wanted to do family medicine because it really was something where it allowed me to work with people and improve their health over time. That was something that really interested me.
Hmm.
And I personally didn't want to get um, too narrow in focus. And so it actually took me by a little bit by surprise when I was so interested in psychiatry.
Hmm.
At the end of the day, I would have probably chosen family medicine if I had to pick. Um, but I was fortunate enough not to have to make that decision.
Gotcha, gotcha. Yeah, that's great. So, how long is the training for the combined program compared to?
So yeah, great question. It's a 5-year program.
Mhm.
So if you think of family medicine as a 3-year program, if you think of psychiatry as a 4-year program,
Mhm.
and combined training is 5,
Yeah.
essentially, it's shorter than doing them both in series. So when you combine them together and you take away the overlap, you save yourself time by doing combined program.
Yeah. 7 versus 5. I'll take 5 any day.
7 to 5, yeah, yeah.
Cool. And do most people end up doing a fellowship, or what other career opportunities with the
Yeah, it's a great question. People who do family medicine, psychiatry,
Mhm.
generally will finish out those 5 years of residency and then work.
Okay.
Um, People who do internal medicine, psychiatry, I would say a higher percentage of those folks end up doing a fellowship, but I think that's really more of a function of internists in general end up doing more fellowships. So it's kind of more the culture in internal medicine to do a fellowship afterwards.
Yeah.
Now, that being said, we've had a number of folks at Davis who went on and to complete. We had one who did a consultation liaison psychiatry fellowship. We had someone do an addictions fellowship.
Oh,
So really, you can do a pain fellowship, you can do a sports medicine fellowship, all the fellowships that one could do as a family physician or a psychiatrist are still open to you if you wanted to do yet more training
yeah.
after 5. I personally felt 5 was good enough for me, and
Yeah.
I went and practiced. I didn't do an extra fellowship.
Gotcha. Uh, Fair enough. What kind of, as a medical students or pre-med students, what kind of characteristics do you think make for a successful family med, internal med, a psychiatrist?
Yeah, I think two things. One, I mean, I think the most important thing is you really have to ask yourself, is doing psychiatry, being a psychiatrist, a part of your future, and is doing primary care or medicine part of your future? In other words, if you say to yourself, "Gosh, I really want to do psychiatry, but I really don't want to like lose my primary care skills, or I don't want to lose my medicine skills."
Mhm.
Once you start residency, you'll quickly realize that the thing that you're most interested in is the thing that you're going to do, right? So anybody who's thinking about doing a combined program really has to ask themselves, um, would they feel a real loss not being able to do both specialties, right? Because once you're in residency, it's going to really test your true passion for those two fields, right?
Right.
So you really have to be interested in both and not just fearing losing one of the two, right? And I think the other really important quality is flexibility because you are going to be doing a combined program and you're going to be going between the two departments at your institution. And some degree of flexibility is really important because you have to think of the two departments in a combined program as they're two boats that are like floating next to each other, and there's going to be a little drift
Yeah.
between those two. They're not always going to be in lockstep with each other. And so sometimes things are not going to be perfectly synchronized, right? And if you're somebody who just really gets all out of sorts when things aren't exactly perfect, it's going to drive you crazy. So I think having a little bit of flexibility is goes a long way when you're going to be doing a combined residency program.
Yeah, awesome. So along that line, what do you find most exciting about the combined program? Or uh,
Yeah, yeah. Having done a combined program, I mean, I will tell you that I'm sure all the specialists who are going to come on to this will tell you the part of what they enjoy is the flexibility of doing different things. But I can tell you, as a family physician and a psychiatrist,
Mhm.
really, truly, there is such a tremendous amount of flexibility in what you can do in a future career. So, I spoke to you at the beginning about what I do, and it's a variety of things, right? I do just kind of straightforward. I've done straightforward outpatient psychiatry. I've done straightforward primary care. I've done consultation work in between. I work with medical students and residents and practicing physicians and health plans on how to better integrate primary care and psychiatry together.
Yeah,
And so there's just such a wide swath of things that one can do. That's something that I really enjoy. Now, and maybe this goes back to your earlier question about like, what's a good fit. I think that in a combined program, you have to be okay with just some things you're just not going to know, right? Some people who go into specialties, they really want to know everything about that one thing. Well, that's just not possible with family medicine and psychiatry.
yeah,
There is so much information out there. Part of the comfort that you have to be comfortable with not knowing everything, certainly in this sort of field. However, there's so many things to learn that you're certainly never going to get bored.
yeah. And then on the other side of the spectrum, what do you dislike or like least regarding the specialty?
Well, I had to take two board exams, so I didn't like that. you know, you have to keep up with two fields, right? I mean, you have to take recertification exams for both fields. So there
Yeah,
is a little bit that extra duty, right?
yeah,
So that's not something that you're gonna have to do if you did one specialty.
yeah,
But of course, it's really interesting. I can look at a family medicine journal, I can look at a psychiatry journal, and both are really interesting to me.
yeah.
So again, maybe if you're someone who really just feels like, no, I really need to know everything about one thing, a combined program is probably not for you.
Yeah, fair, fair. So, can you, I mean, you talked a lot about the different environments, and you mostly work in academic setting. Are there private settings as well that
Yeah.
combined program? Um,
Yeah, I would tell you, I work in academia, but I've worked in a number of different clinical settings. So I've worked, I've had a private practice psychiatry clinic. I've had that for 6 or 8 years.
oh,
I work part of my time in an FQHC. I've worked in a hospital-based clinic. I've worked in emergency psychiatry in a county hospital. So I've worked in lots of different settings, both in primary care and psychiatry. And I will say that as a combined, um, if you do combined training, probably the two best settings are going to be where it's a nice fit, and you don't have to do a whole bunch of finagling. Would
mhm,
be academia, and also working in FQHCs. Because FQHCs, by definition, part of their mission is to take care of the behavioral health problems that the patients have, as well as physical health, right? And who is better at putting those two together than someone who's done primary care and a psychiatry residency program, right? So it's really a natural fit. And a person who works in an FQHC, the way that the FQHCs work is the billing is the same, whether you do psychiatry or do primary care. So it's actually a nice fit from that perspective. The VA also is actually pretty advanced in trying to integrate primary care and psychiatry. So anybody's interested in working in the VA setting, that's also a nice, easy fit. And then in academia, it's just simply because if you were in there's different series in academia, of course, but one of the series really is kind of cobbling together different um, clinical activities, and so that's how I was able to work. Part of my work is at an FQHC, then in a hospital-based clinic, and consultation clinic. So those are two settings that I have found many of the graduates of combined programs end up working: academia, doing teaching and clinical work, and then FQHCs. But I have had a couple of residents over the years when I was at Davis who did work. They split their time doing primary care in a private group setting, primary care group setting, and then part of that their week is in consultation, doing consultation psychiatry for their colleagues in the group primary care setting.
Okay.
So there are different ways of doing it. Um, Sort of where there's a will, there's a way, I suppose.
Yeah. Cool. And then along that line, can you tell us, you mean, how many hours do you normally work per week or month or year or whatever on average? And then describe to us work-life balance.
Yeah, well, I will tell you one of the interesting things that you find in having done a combined program is you kind of see how each side lives, right? So, um, when you're a resident, you see what the life is of a family medicine resident, and then you see the life of a psychiatrist, right? And even now, I see the life of a primary care doctor and life of a psychiatrist, and
Mhm.
they can be quite different from each other, as you can imagine.
Yeah.
Um, the work-life balance is definitely, I would say, easier to maintain in psychiatry,
Hmm.
partly because in psychiatry, the culture of psychiatry is to have like firm boundaries, right?
Hmm.
Whereas in primary care, things are a bit more dynamic, right? That's just part of the culture.
Hmm.
And so what you find is that that balance is probably a little bit tougher to maintain, and the call schedules are probably a little bit tougher in family medicine and just primary care in general
Hmm.
compared to psychiatry. But I will say there's something to be said about just your own temperament, right? So you might find um, the stress of working with people through psychiatric concerns very taxing, for example, right? And so you might find, even though it's maybe not as a great of a demand in terms of time, but it may be in terms of emotional energy, it's more draining.
Hmm.
On the other hand, you might find that working with people through mental health issues is really not that taxing, and so it's quite easy. So I think this is the. I think there's not a easy answer. It just depends on which part of primary care psychiatry practice you find a bit more mentally taxing, I suppose. But I will say, just if you just went and looked at the hours,
Hmm.
primary care is probably more demanding on one's time compared to psychiatry. But if you do combined training, you can basically uh, work the numbers to where you're comfortable, right? So that's the part of combined training. There's such a variety of things one can do. You can really find a niche in the amount of time and effort that you want to do. Whereas I think if you did just strictly primary care, or if you did strictly psychiatry, those things are a bit more fixed. But if you do combined training, because you can adjust the kind of the proportions, you can kind of make it fit to what you're more comfortable with.
Okay, that's great to know. So, with your extensive experience, how has the specialty changed over the years? And then also briefly describe how has it changed with, if anything, with COVID-19?
Yeah, so I think when I first graduated, when I graduated residency in early 2000s, I remember coming out and I would tell people I do combined training, and they would say, "Oh, interesting," and they would think about it for a moment and say, "Oh, yeah, that makes sense. Yeah, what are you gonna do with that?"
Yeah,
Right?
yeah.
There certainly weren't any sort of pre-molded, pre-made sort of positions.
Hmm.
And then about 10 years ago, you started to see a lot more of this focus on integration of primary care and behavioral health.
Hmm.
And then as a program director, I would be getting emails from Kaiser, VA, uh, private group practices asking about residents who are graduating and would they be interested in putting together some sort of integrative program for their organization.
Hmm.
So there's definitely been this shift to integrated care, and who best to lead integrated care than who's done a combined program, right?
Yeah.
So it's definitely gotten easier and easier to find jobs where that's what they're looking for, rather than you having to go there and convince them that this would be good for their organization.
Gotcha.
Um, so yeah, I would say as far as jobs are concerned, that is really you're just fighting off people. And plus, the worst thing that can happen is that you would do primary care or psychiatry.
Yeah.
So it's not as if, gosh, if you can't find a combined job, you're out of a job,
Yeah.
right?
Yeah.
So I think that is the extra sort of safety, I suppose, if you think about it from that,
Yeah.
strictly speaking.
Yeah.
And then with COVID, um, it's you're basically dealing with what the two specialties deal with. Now, psychiatry, interestingly, adapted very easily because there's a much longer history um, with using telepsychiatry for the last
Mhm.
20 years,
Yeah.
whereas in primary care, that's a much newer thing. And so, for example, at UC Irvine, when COVID hit, psychiatry was ready to go. They were on they transitioned very quickly,
Mhm.
whereas the family medicine department really it took several weeks for the transition to happen.
Yeah.
Um, but I think both adapted, but psychiatry certainly adapted easier because there's no typically not a physical exam, so there's that element that is you don't have to worry about.
Yeah. So, just from what you just said, is a fair assessment that the job market for current and future medical students for combined programs pretty attractive?
Yeah, I mean, I guess the word is, I mean, if you could think of it just from that perspective, be nimble, right? Because you have so many different options. If
Mhm.
one door closes, there are several others that are open, right? So, let's put it this way: job security is definitely something I am absolutely not worried about,
Mhm.
frankly,
Yeah.
because there's just so many things that I'm actually have to say no to lots of opportunities rather than, worrying about, gee, am I going to have something to do per se.
Yeah. Yeah. So, what do you see as uh, of the specialty in 10 to 20 years down the road? Any changes you see?
Well, I think that, there's a lot of interest in what's called complex care integration,
Mhm.
and that is really focusing on the proportion of patients in primary care who are requiring a lot of resources and a lot of money because they've got comorbid psychiatric or behavioral health conditions along with primary care conditions, like diabetes, high blood pressure, etc., and depression, for example. So those patients with those conditions end up being very expensive for the system, and so there's a lot of interest now with things like health homes, for example, of we need to do a better job taking care of those patients, and so I think there's a lot of future opportunities for combined trained physicians to fill that niche in assisting health plans and organizations in doing better population health, essentially, and we're helping with those. So a practitioner can do clinical work and then do work with health plans and systems to do a better job assisting those very complicated patients. So I think that's one definite area. And then just really being, for example, a resource for primary care colleagues in a primary care office, helping them deal with patients with behavioral health conditions, and vice versa. So there's lots of ways that combined trained physicians can fill a niche that I think is just going to continue to expand.
Cool. Cool. From a medical student standpoint, what's the one thing you wish you knew sooner, knowing what you know now?
Well, I think um, if I knew that these combined programs were out there, I would have probably done more work to, for example, there's the Association of Medicine and Psychiatry conference,
Hmm.
right? And there's also these fourth year electives at the combined programs where
Hmm.
you can meet people who have worked in combined settings,
Hmm.
where you can talk to them about their experience, where you can actually go and work with them as a fourth year medical student. And that certainly um, would have helped me get a better idea of what a combined training, getting combined training would be like, and what the field has in store. Now, I didn't have that kind of opportunity because, frankly, being realistic, there wasn't anybody who had graduated yet when
Yeah,
I,
exactly.
applied. So I think anybody who's even thinking about it now
Yeah.
really would be well served by going to the Association of Medicine and Psychiatry website and taking a look there because it gives a lot of information about combined training and contacts and that sort of thing. And then really thinking about um, contacting these programs to do an away rotation. I know that right now, this past year with COVID and everything, that's kind of been thrown up in the air a bit.
Yeah.
But kind of going forward, that is something that when I was a program director, that's what I looked for. Does this person who's applying to the program really know what they're getting themselves into,
Mhm.
right? And if they've gone to the Association of Medicine Psychiatry conference, spoke to combined people, did an away rotation, working with people who did combined training, and they're still applying,
Mhm.
then I know they're serious, right? Because I'll tell you that when I was a program director, sure, if you were AOA, that was great and all, but what was most important is figuring out, does this person really know what they're getting themselves into,
Yeah.
right? And one of the ways that was reassuring is they've actually took the time to go out there, go to the meeting, do an away rotation, really ask questions, and that was oftentimes very reassuring to me that that's what they knew what they're in. What they knew what was in store for them. So that's something that I always highly recommend students do if they're even thinking about doing a combined program.
Yeah, those are very great tips for current students and future students
Yeah.
on how to pursue it. You touched base on some of the resources. Do you have any other any other resources that students can go find to look into more about the specialty?
I think the Association of Medicine and Psychiatry is probably the biggest one because and the conference, it's always in the fall. It's always late September, early October. It really caters to medical students who are thinking about combined program.
Mhm.
It's like part of the mission is so that to kind of help students really understand what they're getting themselves into. So I think that would really be sort of the clearinghouse. They have mentoring programs and scholarships to go to the conference. So I would say that really is the best one. The other one clearly would be if you are aware of someone who's combined trained at your institution, going ahead and talking to them. But I'll tell you, if you go to the Association of Medicine and Psychiatry website, you'll probably be able to find who those people are in your area, right? So I think still that's really probably
Yeah,
the best starting off point,
yeah,
is what I would
cool.
say. Yeah.
I think I'm gonna end on the last question. What's your number one tip for students going into or learning about the specialty?
Gosh, I think I just sort of spend a few minutes talking about it. I think really you want to talk to someone who's done combined training. One of the big things you hear is that students have been told is, oh, you don't want to do combined training because you're going to just do one or the other,
Mhm.
right? And that historically was true for people who did sequential training. So before combined training was a thing, people did sequential training. They would do them in series essentially, right? And the most common combination was they would have done a primary care residency first, either internal medicine or family medicine,
Mhm.
and then they did a psychiatry residency. And the reason for that is you would do 3 years of internal medicine or 3 years of family medicine,
Mhm.
and then they would give you credit for 1 year when
Mhm.
you go into categorical psychiatry. So that means you would be able to do both residencies in 6 years,
Yep.
right? Now, if you follow what those people have done in their career, it's usually mostly psychiatry.
Mhm.
Okay, but the thing is, that is really more of a career change than something that one does to do combined things, right? Because you just spent the last 3 years doing psychiatry. Are you going to go back and do family medicine or internal medicine?
Yeah.
Not likely.
Yeah.
And so when people say, "Oh, you don't want to do combined training because you're going to just end up doing psychiatry," they're
Mhm.
really talking about those people who did the sequential training route in the past.
Mhm.
Um, if you look at the data, because we did a survey of people, graduates of combined programs, what are they doing? You see a much more even and varied spread of what people do,
Mhm.
right? And so You're not gonna you certainly don't see that in people who do combined training. So I think that's one thing to I think I say this to reassure people that assuming you really truly are interested in both things, most people who do a combined training will end up doing both things,
Mm.
right? So it's not as if the experience will sort of push you into just doing psychiatry, right? Now, if that's what you're really going to do anyway, yeah, there's nothing that's doing combined training is going to stop you from doing that, right?
Yeah.
Uh, but combined train, most people who do combined training end up doing both things.
Mm.
So I think that's the one thing that I would just say: combined trained physicians do a real good mixture of those two specialties.
Okay. Thank you for that. That's all the questions I have, but I always end with if you have anything else to add that I missed regarding your specialties.
I think I have found it to be a very fulfilling career choice, something that was unexpected, that I was not, really thinking anything about when I entered medical school.
Mhm.
And I think the one thing that it really allowed me to do is just the sheer variety of things, both clinically, but also doing teaching and teaching medical students and residents. So anybody who's really interested, I'd be more than happy to, you know, talk to you if you have more questions. If you want to give them my email
Yeah.
about questioning about any further questions about combined trading, I'd be more than happy to talk to them about it.
Yes, sir. I appreciate you offering to help those who want help. All right.
Yeah.